Andrew, who's going to tell you about the actual design and the setup.
A number of years ago, Oliver Fien and a colleague at Metanomics Health distributed a white paper kind of trying to gauge the interest in the idea of improving metabolomics, ultimately for the goal of moving it towards, say, translational applications. And this clearly reminded me of CLIA registration and the goal for clinical laboratories to ensure that the standards and patient data are accurate, reliable, and reproducible. And actually, if you look at the law, it also says timely, although I don't know how true that is anymore. But similarly to physicians wanting accurate data for their patients, the metabolomics field should, similarly and likewise strive for the delivery of the best data possible. And I think ultimately this is kind of the goal of what these trials are meant to achieve and do. So, why are ring trials important? This was again addressed in the white paper, but more importantly, to kind of address the idea or the lack of perceived reproducibility. And I put perceived in quotation marks because this is something that we haven't looked at in a hard way with hard and fast data. And this is one thing that the ring trials itself will achieve, will generate data such that we can then make meaningful conclusions about some of the questions we're asking. So along with reproducibility, of course, robustness and overall value. And of course, overall, this is a larger question I think science in general is struggling with right now in terms of reproducibility. So next thing is, of course, to kind of address, the lack of, or more importantly, the lack of adherence to common standards. And by that I mean reporting standards, in terms of metadata. How do we report chemicals? How do we report metabolites? Protocols we've used. And we've all been involved in reviewing of papers where this is not necessarily always held to in terms of the editorial process. Another thing that can be achieved through this is the idea of best practices, and by this I mean what protocols or platforms, data analysis tools work best, and for which purposes do they work best. As global profiling, targeted, which biofluids, which tissues yield the most meaningful information. And of course, the idea of QA/QC and how do we assess the reliability of data, and what should we be including in our data sets such that we can then evaluate how reliable this data is. And as I already mentioned, of course, these types of ring trials hopefully will then provide data that will allow us to, or permit us to discuss it and facilitate discussion such that we actually have something to go from. So what do I mean in terms of best practices? And I just use here, and this is data from my own lab, unrelated to the ring trial, but we just take a simple short chain fatty acid example, and shown here are two plots where we're looking at short chain fatty acids either by GCMS or proton NMR. And if you look at the methods that we could at least look at short chain fatty acids by, say, GCMS, we could go no derivatization. We could generate propo or butyl esters or PFBB or et cetera, Which ones work the best, which ones work most reliably and quantitatively, I think is something that has yet to be determined. Of course, we can also look at the substrates for the generation of these short chain fatty acids, so oligosaccharides and polysaccharides. And we can look at it by NMR. We can even go even further and do it by bomb calorimetry, kind of the old-fashioned way to make sure that what we're looking at is indeed robust and reliable. And I put this up as an example that was suggested by Lauren McIntyre in arts group to suggest that this is very reminiscent of the story of the blind men touching the elephant. And if you bear with me just a little bit, we think of the elephant as, say, acetate, for example. Well, we could describe it in terms of a chemical shift, 1.9048 ppm, or perhaps we've methylated acetate. In this case, we can refer to it as it's fragments 74, 59, and 43, or we can look at it directly, in which case we're looking at 60, 45, 43, and 29. We're all measuring acetate, but we're doing it slightly differently, and how this ultimately leads to the measurement and reporting of acetate, I think, is quite important. So if we step back, this is nothing new that we're actually doing. Historically, ring trials have been done in a number of fields. A very good example is with the OPCW, where they're looking at chemical weapons and essentially making sure that the countries that are involved in this chemical weapon testing can do so in an accurate and reliable way. However, of course, there's also diagnostic tests that are important for clear registration, and also the genomics, the transcriptomics, the proteomics field, even the metals community has undergone these ring trial, round robin proficiency tests, if you will, over the last several years. So if we just take a look at a summary of some of the historical ring trials, we can look at them in one of two ways. The first being platform-based studies, where looking at examples of how NMR is useful for metabolomics, GC-TOF-MS, NMR, QTOF, or Orbitrap comparisons. These are all studies that have been published in terms of environmental chemistry, up to now a recent publication in metabolomics comparing not only multiple platforms but also multiple labs. Just to look at some of the conclusions that came from these studies, by and large, NMR-based metabolomics did very well. It's an ideal technique, generated very highly comparable data sets within and across the laboratories. But the one thing I think that most of these studies took from it is that rigorously controlled studies, in this case, using the same instrument, the same extraction protocol, the same type of data analysis approach, yielded very highly reproducible data within and between laboratories, and this was independent of platform. And some of the questions we've had throughout the protocol exchange working group has been, well, is this really necessary, and is this something that we should be concerned with and worried about? Also, there's biofluid-based studies, a study by Paul Benton looking at urine as a biofluid. Essentially, he found in this case, looking at an LCMS approach, that it was a very excellent tool, in this case looking at very targeted profiling. However, he cautioned at the end of the study that it's very important to worry about quality control, such that we can ensure that these results are reproducible within and between laboratories that were included in the study. More recently, the ABRF completed an interlaboratory study. I believe it's now in press or close to being in press. I thank Rita and the MRG working group for providing this slide. Just to summarize some of the results, they found in this case that LCMS systems did quite well compared to NMR and other platforms. This is not necessarily, maybe reflecting of the types of chemicals that were to be measured. However, this is what they found. For the LCMS platforms, they found the accuracy was extremely dependent on the type of protocol that was used for sample processing, and as well as the analytical conditions. By this I mean column chemistry, mobile phases, temperatures, and things along those lines. The quantitation trends were very consistent between laboratories, as well as with the LCMS platforms. And interestingly, one of the challenges they faced is when looking at trying to examine data from very highly abundant metabolites. This is where the results became a little bit murky. However, overall, to summarize, what they found is that a combination of those platforms increased both the accuracy and the overall rate of detection. In this case, a simple spike-in study looking at spike-ins into plasma. So what are some of the objectives that we at least initially agreed upon? And we were hoping to assess some or all of the following, and that is to understand the complementarity of platforms. So by comparing NMR, GC-MS, LCMS, or the variety of other platforms that are used throughout the ring or the RCMRC community, as well as individuals outside of the community, how complementary are the data that are generated? What's the comprehensiveness? How many metabolites and features are we actually detecting? What's real? What's not? Importantly, metabolite annotation. This is something that hopefully we're working towards in terms of establishing more adhered to standards for identifying, or basically how you report a metabolite as being identified or not. Data quality, precision and accuracy, and also the varied statistical approaches that the groups took to analyze their data set, and also the strategies that they took to analyze those data as well. So looking a little bit at the ring trial protocol, in this case it was a bit of the Wild West. So the labs were free to use any extraction protocol, any platform, any data analysis tool of their choosing. So this maybe represents a little bit of a ultimate headache for Owen, who has to look at the data. But this is something that I think represents what's actually occurring in the real world. And we're all doing things slightly differently, in some cases very differently. And what are we arriving at in terms of complementary data sets? We made no attempts at standardization for this round, meaning we did not demand that certain protocols be followed. We did not suggest the labs do anything one way or the other. However, I think in future rounds we might consider a more structured approach where these details are provided and strict adherence to these protocols is important. So what did the ring trial design look like? Well, there were two components, metabolomics component and an analytical component. The metabolomics component consisted of a series of samples that came from either male, female, or pooled samples. So there were 20 male samples. I should say they're not blind males. The people were blinded to the samples. Sorry, that reads a little funny. The males, there was 20 males. Each lab was given 5 mil aliquots of those samples. Female plasma, again, 20 samples, 5 mil aliquots, and pooled samples that were generated by combining these 20 males and 20 females into a large pooled sample and then aliquoted and distributed. There was also an analytical component, in which case we looked at, or we spiked into pooled serum samples, 40 standards representing both xenobiotics, so foreign chemicals, and endogenous compounds. In this case, they were spiked at levels that were well above background, so there was no really having to dig around in the grass to find these metabolites. Also, these were spiked at different concentrations into 5 tubes of plasma containing different concentrations, and these were randomized, as well as the samples from the males, females, and pooled samples were also anonymous. So the labs did not know which was a male, which was a female, or pooled sample. It was their job to determine what was what based on the strategy that they took. So taking a look at the demographics of these patients, at this point, we did not restrict them in any way, shape, or form. We did not restrict them to an age group, a BMI, a race, or ethnicity. They were also verbally screened for drug use and smoking status. They were not assayed for these drug use or drugs of abuse, as well as smoking. They were just verbally screened. They were also collected in the non-fasted state, which will be important for a point I'll talk about here in a second. And in this case, we chose lithium heparin as the anticoagulant. Just to give you a breakdown of the two groups, we had 20 males ranging in age from 20 to 66. So the average age was about 41 and a half years old. And the BMI was on average 28, but ranged from 22 to 36. So representing a pretty large span of BMIs. Which was even greater when looking at the female group. In this case, the age was quite similar, although ranging from age from 22 to 59. However, in this case, BMIs range from the low end of 19 to the rather high end of 52. So along the way, there were a lot of questions about the choice of anticoagulant, and I think this is one of the things that we discussed quite extensively, and the reasons for choosing one coagulant over the other, I think, is actually there's some recent papers about this recently published. However, our rationale, or I should say Penn State's rationale for choosing lithium heparin came from these two papers published in Nature Protocols a number of years ago. The first coming from a large study of human plasma, and in this case suggesting that the preferred use of lithium heparin was recommended for the use of plasma samples given to some of the interfering peaks generated with, say, citrate, which obviously will interact or interfere with endogenous citrate levels in the samples. For NMR, we similarly also chose the anticoagulant lithium heparin as well. Again, and this is certainly something that has been strongly debated, and in fact suggested to be perhaps wrong, is that in this case, to avoid EDTA, citrate, and other added stabilizers, since they generate additional signals in the NMR spectra, in this case, this group recommended again to use lithium heparin. And again, this is not suggesting that this is the ideal anticoagulant, it's just the rationale for the reasons why we chose this in the samples that we generated, or that we shipped out. So what did the sample preparation look like? The samples arrived at Penn State and were thawed overnight at 4 degrees, and then for a few hours on the bench to completely thaw, at which point the samples were placed back on ice and vigorously vortexed and aliquoted for the individual assays. And again, in between each aliquot, they were vortexed. However, also some of those samples were pooled from the male and female samples, and they also were aliquoted for the pooled samples that were to serve as part of the metabolomics component, but also to serve as the spike-in matrix as well, and were then frozen at -80 until shipping. Some of these samples were reserved for us to do some quality control, in this case using a combination of NMR, LCMS, and LCMSMS and targeted profiling, and that consisted generally of the following. We did a series of proton on NMR experiments, a lipidomics approach on the waters, on the AB-Sykes 5600 triple TOF. We've also completed a ion pair LCMS Orbitrap run, and also did some targeted profiling as well. And then ultimately all this data was analyzed to support if we could tell males from females based on metabolomics. So what were the challenges? And at least initially, the largest challenge was trying to negotiate agreements between 3 institutions, and that being Penn State, UCSD, and the participating lab. And regrettably, I've learned more about the MTA process than I care to admit at this point. In fact, we are still, even to this day, negotiating MTAs with certain groups that would like to participate, however, are prevented from doing so because of unique agreements that are required either by a company or by a participating lab. And along the way, of course, we learned that certain states, California in particular, has very unique rules, particularly when dealing with universities within their own state. And also, of course, trying to negotiate MTAs with different countries, also various different industries, all have different rules, regulations, and issues with data use, and importantly, in terms of confidentiality. And this was a very important component not only for the RCMRC groups, but also for the industry partners that were involved. IRB approval was thought to be expected to be rather simple. However, despite that, a lot of or these samples should generally be considered exempted because they are anonymous. You know, we didn't know. In fact, we purchased them, so they came from a company that provided them anonymously, gave us documentation to support that fact. However, several institutions required more documentation to allow their IRB committees to make final recommendations. Lastly, kind of as I hinted already, there were some issues with sample quality, and how these arose. I think we're still trying to work through. One of the large, or probably one of the very overwhelming factors, is the fact that we collected these from non-fasted individuals. And as you noted in the previous slide, some of the BMIs of these individuals were quite high, suggesting that they have an overabundance of perhaps lipid in their serum, in their plasma, excuse me. There was also very high levels of suspected fibrin and fibrinogen in these samples as well, and some of the suggestions were that these perhaps came from habitual donors. Again, these samples were purchased from a company, and for one reason or another, we saw very high levels of these samples or these compounds in the samples. Also, as I already indicated, there was some discussion about lithium heparin versus other anticoagulants. I've learned along the way that lithium heparin perhaps is not ideal choice of anticoagulant for NMR. In fact, there are others to support, that may be more suitable. However, in general, this is the route that we took, for better or for worse. So I just want to suggest a potential ring trial design for the future. I mean, this is just something that's come from my own personal view of how they should work. Importantly, this includes the RCMRC groups that have already participated. However, there are avenues for industry and other academic institutions to participate that aren't necessarily part of the Metabolomics Common Fund. And ideally, and for future, these are studies that should be rotated across the different RCMRCs. Ideally, the RCMRC that's actually in charge of the protocol at the time should not be identified. In this case, it keeps fingers from being pointed, and ultimately would be the samples distributed by some kind of distribution or validation lab shown here in the center. And the reason for this is that it reduces the need to get new MTAs approved, because every time you would have to do it, it'd have to be a new one initiated. Also, we think one of the challenges we faced is to have an independent oversight committee in the future that would serve to help discuss the trial outside of the participating institutions, and of course, to allow other labs or this validation lab to have capabilities that are representative of many of the participating groups, including LC, MS, GCMS, NMR, etc. And of course, this allows everyone, once the samples are to be shipped out or before they're to be shipped out, to make sure that those samples are okay and that any issues are identified prior to labs receiving them. Ideally, it would be nice to complete this trial one time a year and ultimately report these results at meetings such as this or the Metabolomics Common Fund. So with that, I'll turn it over to Owen, who will then discuss some of the analysis plans for this data.